Vandana Iyer. Yeah, so Dr. Vandana will be presenting on chronic myeloid leukemia masquerading as vitreous hemorrhage in the eye.
I'm Dr. Vandana Iyer from AIOCMT3. First of all, I would like to thank AIOS to give me this opportunity to present in front of you. This is an interesting case of a 23-year-old male who presented with sudden painless progressive diminution of vision in the right eye for past 5 days. This was preceded by a painless progressive loss of vision in the left eye. Onset was unnoticed, probably it was past 3 weeks. It was a chronic tobacco user for past 5 years. The negative history was unremarkable. On examination, right eye vision was 612, while left eye was PLPR inaccurate. Both eye pressures were normal. Right eye anterior segment examination was normal. Left eye revealed a RAPD and a reddish reflex behind the lens, behind a clear lens. On fundus examination, the right eye showed hyperemic edematous disc with dilated tortuous vessels on the posterior pole and scattered white-centered hemorrhages, also called rot spots, and pre-retinal hemorrhages all over the fundus. Left eye revealed a massive vitreous hemorrhage. A diagnosis of differentials was placed: right eye impending CRB of the young, coagulopathy-related retinopathy, anemic or leukemic retinopathy, and left eye vitreous hemorrhage due to any of the above. On ocular investigation, right eye OCT revealed thickening of the retinal nerve fiber layer, no macular edema, while left eye revealed a massive vitreous hemorrhage on B-scan. The blood investigations further found that the patient was anemic grossly with an HB of 7.8 gram per deciliter. WBC count was more than 5 lakhs per microliter, and peripheral smear revealed neutrophilic leukocytosis with marked left shift and myelocyte bulge, which was suggestive of chronic myeloid leukemia. Empirical treatment was started on tablet hydroxyurea with febuxostat. Further investigation with RT-PCR revealed BCR-ABL mutation positive, that is Philadelphia chromosome positive. Definitive treatment was started on imatinib methylated tablet, and hydroxyurea was stopped. So we expected the patient to improve actually, but 2 days later we saw that the patient had worsened and the right eye was looking more aggressive with worsening of disc edema and rot spots. Left eye showed a spillover bleed from the posterior to the anterior chamber, causing total hyphema. The pressures were increased to 42 millimeters of mercury. The B-scan ultrasonography now showed a central clearing. This looked more like a total retinal detachment with subretinal deposits. Probably this could be hemorrhage or tumor infiltrate. So we actually discussed the case with a hemato-oncologist and an ocular oncologist. So several postulates for left eye worsening were placed. Either it was a direct invasion of tumor cells or indirectly thrombocytopenia, anemia, reduced platelet and bleeding tendency leading to the accumulation below the subretinal space. Pseudo von Willebrand factor deficiency associated with CML. Side effect of chemotherapy, that is imatinib mesylate, is known to have been associated with platelet dysfunction. Then blast transformation of CML to ALL. This ALL or even AML, this seemed to be the most plausible reason. So our ocular pathologist advised us to give intrathecal dexamethasone. But the patient's platelet count at that point in time was less than 50,000. So we had to start him on intravenous dexamethasone. So this is a fundus picture. The patient again improved in 2-3 days. The right eye drastically improved, the vision improved to 6/9, and the rot spots disappeared and the disc edema also reduced. Left eye, the intercalary cephaloma resolved. The pressures also decreased from 42 to 18, and the hyphema became organized. So CML is initially treated with hydroxyurea, is followed by imatinib mesylate when we have proven the diagnosis. If we find that there is any worsening after starting the chemotherapy, then we have to start the patient on intrathecal dexamethasone. If it is greater than 50,000 platelet count. If platelet count is less than 50,000, then we will start on intravenous dexamethasone. Newer modalities are also there in the form of injections of dexamethasone or intravitreal anti-VEGF or methotrexate. So this is my take-home message. CML masquerading in the eye is a rare occurrence. If it's not responding to routine treatment, it may be due to blast transformation. So it may need treatment modification and multidisciplinary approach may be needed. These are my references.
Definitely an interesting case, Vandana, because this is really a very rare occurrence. Generally, orbital manifestations are seen, but intraocular and that too mimicking these type of vitreous hemorrhages is rare.
Yes.
So a very well documented case, Vandana. Again, when the patient initially presented to you with that right eye multiple hot spot, left eye vitreous hemorrhage, was he already a diagnosed case of CML?
No, ma'am. So he just presented as a vitreous hemorrhage, and right eye was absolutely normal. He is a normal young male walking into our OPD, and drastically worsened after finding out that it is CML. We thought he will improve, and it was contrary to our expectation.
Yeah, but that is very important, to know these features. That's what we were discussing in the last case as well. To know this as a typical fundus finding of a patient with CML and going ahead with just a peripheral blood smear helps.
Yes, ma'am.
Thank you.
Thank you.
In these type of cases with vitreous hemorrhage, you would like to clear up the vitreous with vitrectomy or not? With these type of blood counts with the patient?
As the reports it won't suggest it's something else, then we can go back.
We can go to have a
Better,
view
yeah,
and
better
all that
view,
stuff.
better
But
So
that
because the pressures were so much that we were actually trying to lower them and then only wanting to intervene. And after this, the patient was lost to follow-up also, so we don't know what happened.
okay. Thank you.